Okay, good afternoon. Today I'll be presenting on my dissertation research, which I conducted with the Turtle Mountain Band of Chippewa Indians as part of my program at the University of Minnesota School of Public Health. I recently finished my degree here in December, and I conducted this study on risk factors for breast cancer among American Indian women. So here's an overview of my presentation today. I'll be talking about my inspiration, background of my study, the methods, the results, discussion, and future directions. Here's a picture of my mom and my dad. My parents are both from the Turtle Mountain Band of Chippewa Indians. My mom is Shirley Black Eyes Bellegarde, and my dad is Raphael Jack Nadeau. They were together until I was 2 when they ended up getting divorced, but I was very fortunate in that they let me go back and forth between them as I was growing up, so that was nice. Here's a picture of my dad. This is one of my favorite photos of my father. He's actually sitting at the Bureau of Indian Affairs in Belport, North Dakota, Turtle Mountain Band of Chippewa Indians. And the significant thing about this picture is that he's actually sitting in front of a relocation sign. The relocation was a program that was geared towards Native people and was designed to, some people say, to get them off the reservation and to have them integrate into mainstream culture. My father, though being, just 21, he had just gotten back from the Army. He was looking for an opportunity, and he saw this as an opportunity since there was no jobs in Turtle Mountain to relocate and find employment. So he actually took a one-way ticket out to California on relocation and stayed in a boarding house, and he was out there for about 3 years. Both of my parents also attended boarding schools growing up as well. Here's a picture of my mother and my siblings, and this was after my mom. My mom went out on relocation too, but after they had separated, she had decided to move back to Turtle Mountain, stay on the reservation, and so I was with my dad until like 3rd grade, and then I moved back to the reservation and stayed with her, and it was an eye-opener to go back into that environment and really realize the lack of resources that were available at that level. I did a digital story a couple years ago that I'd like to share with you at this time. Here's a picture of me in the 3rd grade. At this age, I started thinking about what I wanted to be when I grew up. This is a picture of my Uncle Benny, Dad, Mom, and Uncle James. My Uncle Benny died from an unintentional injury, my mom from cancer, and my dad was with diabetes. Both of my grandparents passed away from cancer. My Uncle Davy and his daughter Ivy were shot and killed by the same bullet. My Uncle Edward passed away from cancer. Eventually, I would go on to college as a first-generation college student. Experiencing all of this loss motivated me to pursue a health career. My Uncle Bernard passed away from an aneurysm. My cousin, Bernard Jr., passed away from cancer. My stepfather passed away from an unknown cause. My Uncle Francis died of asphyxiation. Right before I graduated with my master's degree in public health, my father had a toe, partial foot, and a below-the-knee amputation due to his diabetes. I'm happy to report that it's been 4 years since his amputation. His first prosthetic leg says
reality. It has lightning bolts on it. The fall of 2010, I entered into the PhD in epidemiology program in social behavioral health.
And so that brings me full circle to where I'm at now. Like I said, I recently completed my degree, and I'll be walking in graduation here in a couple weeks, so I'm really excited about that. As a student, it was very important for me to stay engaged with my community, and I did that in a number of ways. I worked a number of summer externships at the Indian Health Service. I worked for tribal projects throughout my career, actually, prior to even going to the University of Minnesota. But while I was at the University of Minnesota, I was very fortunate in that I was able to work on the American Indian Community Tobacco projects for about 4.5 years. I attended a number of conferences over the years, have been awarded numerous travel scholarships to attend these conferences. I've attended health fairs, and actually worked as a consultant for the American Indian Health website that is sponsored by the National Institute of Health, and did a lot of information sharing at health fairs over the years, attending trainings, and then, most importantly, my proposed dissertation was with my community, and that's what I'll be sharing with you today. So when I first got into this, when I was looking for a dissertation project, I realized I did a literature review, and I realized that there's a breast cancer risk calculator that you can find on the internet, and it's a calculator that providers use to calculate the risk of an individual's getting breast cancer. This is a mathematical model. It's commonly used by physicians. There's more than one calculator. The one that's online is the Gale calculator, the Gale breast cancer risk calculator, but there's others. There's Rosner and Folditz, and others that are used to calculate risk. Risk prediction models, they're used because they give data-driven breast cancer estimates. They're also very useful in studying and raising awareness of breast cancer, and they help clinicians by helping them to inform the decisions that they make in the clinic. So these tools are used to determine whether or not their patients would be good candidates to participate in clinical trials. They're planned to inform and design interventions, and also counsel women about the risk of disease. One thing that I noticed when I came across this is that the tool has been created primarily for whites, and the work that has been conducted with the white population actually started in the early 70s, and since then there has been limited work done for Hispanics, Asians, and African Americans. So the tool has been adjusted for these populations to better reflect the risk factors and considerations for those populations. However, I noticed that nothing exists for American Indians. I also noticed that there was extremely limited information about the risk factors for breast cancer among American Indians across the nation as a whole. Risk factors included in the model currently include women's age, age at first live birth, age at menarche, the number of previous benign breast biopsies, and the number of first-degree relatives with breast cancer. There were a number of risk factors that were considered over the years, going all the way back to the 70s, and these included medications, cigarette smoking, and just to note, the cigarette smoking that was looked at was moderate use only. methylxanthine consumption, modest alcohol consumption, and long-term menopausal estrogen therapy. There's 3 things that are required in order to create a breast cancer risk calculator. If you want to create a breast cancer risk calculator, you need the relative risk for risk factors associated with breast cancer for the population of interest. You also need age-specific breast cancer incidence rates for those with and without the identified risk factors. And then you also need to adjust the model for competing causes of death. So none of these things have been done for the American Indian population concerning a calculator. However, other minority populations, the model has either been adjusted for considering all of these factors, or it's been partially adjusted with certain information. So it varies across the spectrum. Like I said, not much is known about the breast cancer risk profile among American Indian women. So when I conducted the lit review, I was able to find one study that was conducted in 2005 by Chabalsky et al. And what they did was they examined data from the Women's Health Initiative, and the Women's Health Initiative study includes approximately 156,000 postmenopausal women. They were recruited from 40 health facilities across the United States. The age was 50 to 70. Whites representing 82% of the sample, so approximately 129,000. American Indians, however, and Alaska Natives represented less than 0.5%, with the N being only 696. So that's basically what I had to look at in the literature, was this one particular study. But as you can see, it was extremely limited for the number of American Indians that were represented in this sample. But, you know, it was all I had to look at, so this is what I had to use to inform my decision making. And so what I did was I looked at the risk factors. So on the left-hand column, you'll see the characteristics for breast cancer risk factors that are included in the model. So the first row, you see first-degree relatives with breast cancer. And I noticed that, you know, American Indian, Alaska Native women were more likely to have one or more first-degree relatives with breast cancer. When I looked at age of menarche, and that's in the second row, I noticed that more American Indian women were age of menarche was 13 or younger for that particular population. As for age of first birth, I noticed that there was a smaller percentage of American Indian, Alaska Native women that did not have children. I also noticed that the number of previous benign breast biopsies was a smaller percentage among American Indian, Alaska Native women. And then I noticed that the BMI of 30 or greater was higher among American Indian women. And I noticed that a higher percentage of American Indian women had greater than 5 children. So based on this information, I decided to look at all of the factors that were included in the Gale model among the American Indian population that I was going to do the study on, which is the Turtle Mountain Band of Chippewa Indians. And I also decided to include BMI and parity. So here's the background about the study that I conducted. It was American Indian women at Quinton N. Burdick Medical Healthcare Facility at IHS in Belfort, North Dakota. I explored the risk factors included in the Gale model, BMI, and parity. So although it was not the focus of my study, I had to estimate breast cancer incidence rate. And the reason that I had to look at this is because I had to determine whether or not my study was feasible. So that wasn't too difficult. I was able to contact the cancer registry in North Dakota and ask them for the number, the incidence rate and the number of cases that were that occurred in Belfort. And so once I had that number, I knew that I would have enough patients to power my study, but I had barely enough. Like, I had to pretty much get a high percentage of the people that I was hoping to get in order for my study to be powered adequately, and thank goodness I was able to do that. So it was a concern because a lot of the health assessments that are completed for American Indian women, you're going to see that there's inaccuracies because of racial misclassification. And what happens there is an individual will go into a clinic and the provider will assume they're white, even though they're in fact American Indian, or they can assume that they're another race. So they call that racial misclassification. So they're misclassified by race, and that changes the data and what we see. There has been efforts to link Indian Health Service data to the cancer repositories, but they are the cancer data centers, but and that is good, but not everybody gets seen at Indian Health Service, so you're not totally dealing with the issue when you approach it in that fashion as well. Also, there's a lack of data collection efforts, and registries only collect data for certain geographical areas, and this limits the generalizability of the information that you're finding. American Indians represent the smallest population, and probably most importantly is that there are geographical differences when you're looking at cancer data across the United States. So to look at a national number is, I personally do not recommend using the national numbers because it's an average of all of the American Indian population incidence rates that you're seeing, and it might not be a very good picture to look at because the geographical differences are pretty significant for not only cancer but other health conditions as well. And there's limitations based on the data source that are used as well that need to be considered. So the specific aims for my study were to collect information that would help to establish which characteristics put American Indian women at increased risk for breast cancer. And I also wanted to calculate the magnitude of risk factors associated with breast cancer in this population. So just to put this back into context, what I ended up doing for this study was one of the three things that need to be done for a breast cancer risk calculator. So this was a small but very important part of hopefully eventually informing a calculator among American Indian population. This is a case control study. It was conducted in Belfort. And why I chose Belfort? I chose Belfort for a number of reasons. Probably most importantly because it's my home. It's where I'm from, being an enrolled member of Turtle Mountain Band of Chippewa, and also graduated from high school there, and I'm also a graduate of the tribal college as well. So it's very important for me to serve my community and to try to collect information that's going to be useful to my community. The Indian Health Service in itself actually holds data for a very long time. So they will send after 7 years, say that somebody is deceased or they no longer are seen at the facility, they have moved, their clinical records are sent to the National Repository. So that doesn't happen in mainstream healthcare facilities. They destroy the records after so long. So to be able to conduct this kind of study wasn't feasible because IHS does keep their data for so long. Some of the I will talk about the challenges I did face collecting and gathering those charts, but at the end of it, I was able to with the help of other individuals, I was able to successfully complete the study, which was great. Okay, now we'll review the methods. So as far as getting approval, my classmates, would have to go through the University of Minnesota IRB for their dissertation research. Being that I was working with a sovereign nation, tribal nation, I had to go through a number of additional levels of approval. I had to get approval from the Turtle Mountain Band of Chippewa Research Review Board. I had to get approval from the Indian Health Service Great Plains Institutional Review Board. That is because I was working with Indian Health Service data. And when you're working with Indian Health Service data, Great Plains IRB can determine whether or not going through their IRB is sufficient, or if they also want you to get national approval as well. They did not require that of me, but it's not unusual for them to do so. And then I also had to get a tribal resolution and a letter of accommodation from the CEO at the Indian Health Service stating that she was going to accommodate me being and utilizing the facility in order to conduct this study. This was a hospital-based case control study. The criteria that I used for inclusion, these women were pathologically confirmed incident invasive breast cancer cases. Case ethnicity was determined by the fact that they were able to be seen at the Indian Health Service. Controls were women in IHS files without breast cancer and without a mammogram. I mean, with a mammogram, excuse me. Everybody in the study had a mammogram. The case control identification process, I used the Resource and Patient Management System, commonly referred to as RPMS. And I had a mentor, Dr. Lyle Best, and Dr. Lyle Best, he actually retired from Indian Health Service, and he conducts research in Belfort, but also in other areas of Indian country. And he, being that he was a previous medical director, he was familiar with the IHS system and was able to mentor me through a lot of the processes and things that I ended up having to deal with. But one of the things that he assisted me with was he was able to query the system using ICD-9 code 174, and he provided me with a list of women that had been coded as having breast cancer. But of course I turned around and made sure to go into the chart and confirm that. And I did have to eliminate some of my cases because I wasn't able to confirm a pathological diagnosis for them. So there were 170 patients with a possible breast cancer diagnosis. Pathological diagnosis was confirmed for 141, approximately 83% of the patients. And for each case, 2 controls were selected when possible, and so I had an N of 278 for the controls, and then 141 for the cases. My controls were frequency matched within 5-year age categories to my cases. Controls were selected based on the mammograms that were closest to the case of diagnostic mammogram, so that's how I selected them. I used the breast cancer risk questionnaire, and this is a questionnaire that's administered whenever a woman goes in for a mammogram. And so from that questionnaire, I was able to find that questionnaire in a lady's radiology file, and I was able to collect women's age, age of menarche, number of previous benign breast biopsies, and the number of first-degree relatives. As far as BMI and number of live births, I had to retrieve that information from the electronic record, and then age at first live birth I had to retrieve from the chart. So here's the form, just to give you an idea of what the form looks like, and that's kept in the chart and the information that is collected. Here's a breakdown of the radiology, electronic, and medical chart review that I completed, and I broke it down by % complete for cases and controls. So across the top you can see that I had a total of 419 individuals in my study, had 141 cases and 278 controls. I completed radiology review for 110 of those cases, electronic review for 102, and medical chart review for 70. And then for the controls, I completed radiology review for 278 controls, electronic review for 277 controls, and medical chart review for 141. No radiology review was completed for 31 of the cases because after 7 years, unfortunately, the radiology file is destroyed. So it's not sent to the National Repository. So for those cases, I had to do chart review it to extract that information. And the archive charts are kept, when I had mentioned that they're sent to the National Repository, they're kept at the Federal Records Center. And when I first started conducting my study, Medical Records was able to send for, I want to say probably my first 10 charts, and then they just said, you know, we just don't have the funds in our budget to support this kind of record pull, because cancer patients, you know, it's not unusual for them to have a whole box full of records just for one cancer patient, and it's very expensive. You know, the charts are very heavy, and the shipping and handling gets very expensive. So at this point I was pretty concerned. I was worried that I was going to have to start my dissertation over and choose another study, because I wasn't able to retrieve those records out of the repository, and I needed them in order to have enough people to power my study. So I talked to Dr. Best, and then Dr. Best was able to contact the director of IHS, who was Dr. Yvette Robidoux at the time, and she put him in touch with Dr. Michael Bartholomew, who was the head of the research and epidemiology department, if you will, at IHS and in Rockville, Maryland, and he actually transferred approximately, I think it was $1,340 from his budget to IHS in Belfort to pay for the shipping and handling for my records. So I was very thankful, because although I did have a grant to support my travel, which I was willing to use to pay for my records, Indian Health Service is unable to accept outside funds, so that wasn't an option for me either. So I was very thankful for Dr. Michael Bartholomew for being able to assist me with that. Here's a breakdown of the missing data. The missing data I was able to impute and deal with that in my analysis. I didn't have any missing data that I was really concerned about. It was pretty low across the spectrum, and so I was pretty pleased with that. So for categorizations of the variables in the statistic analysis, I took two approaches. I analyzed the data, and I categorized using the original Gale model categorization, and then I also categorized according to their distribution. And the reason that I did that, because when I looked at the Gale model and then I did my analysis, I wasn't able to find anything for the most part. And then, so I looked at my data, I said, well, hey, maybe, you know, the distribution of data by population is different, so I should look and see if these are the right categories for this population. So I worked with a epidemiologist, a medical doctor, and a biostatistician to determine what would make sense as far as categorization based on the distribution of the population in Turtle Mountain, and came up with new categories and analyzed the data using that approach as well. The statistical models that I did for my analysis, I conducted an unconditional logistic regression that included all the variables in the study, and then I did a multivariate unconditional logistic regression with variables included in the Gale model. I also did a multivariate unconditional logistic regression model with variables included in the Gale model plus EMI. And then I did a multivariate unconditional logistic regression with all the study variables except for age at first live birth. So now I'll share the results with you. So here, across the top, you're going to see the type of models. So I just reviewed these for the 4 different biostatistical models that I conducted here. And then this particular these results are based on the Gale model cutoffs. And then down on the first column here, you can see the risk factors. And so I have highlighted in red and circled those findings that were significant. So as you can see, the majority of my findings were not significant. The other thing that I noticed here is that the trends were not the same. So like, if we look at age at first live birth, for example, you can see that age 20 to 24, the odds ratio is 0.87, and then age 20 to 29, or 25 to 29, the odds ratio is 0.69. So you can see it decreases. Then 30 and over, it increases back up to 0.72, and then for no children, it's 2.28, but it's not significant because my confidence interval is crossing 1, so it's not significant. So nothing in this column is significant, but with the original Gale model, what we've seen with the other populations is that you'll see increased risk as you're going down this column, but I did not see that trend. It increased, decreased, and I see that across my data. There's not a consistent trend in the data. The data is not significant. The things that did come out significant is when I looked at the univariate for age at first live birth, they were not, nothing was significant. However, when I put all of these factors in the model for multivariate for the Gale model, I can see that not having children was significant at 2.54, and then I also seen that maintained for model 2. Same thing for age at onset of menstruation. This age of 12 to 13 for some reason was significant in the multivariate models. And then for not having children, again, for parity for number of live births, that showed up in these models as significant, but nothing else. Again, lack of consistent trend, so didn't see anything. So then my next step, what I did was as I previously explained, I looked at the distribution and worked to define new categories. So if I just back up here, you can see my categories for age at screening were above and below 50 years of age. Age at first live birth was 20, 20 to 24, 25 to 29, greater than 30, not having children. Age at onset of menstruation was greater than 14, 12 to 13, less than 12. Number of previous benign breast biopsies, 0, 1, greater than 2. Same thing for a number of first degree relatives. BMI less than 25, 25 to 30, greater than 30. And then parity, not having children, 1, 2, 3, 4, and greater than 5 births. So once I looked at the distribution of the information that I collected, I came up with new categories. So now instead of 50, I had greater than, less than 56. Age at first live birth, I had less than 18, and then 18 to 19, 20 to 21, greater than 22, not having children. You can see my breakdown for age at onset of menstruation, and then number of previous benign breast biopsies. Basically, we're collapsing down from 0 to greater than 1. Same thing for first degree relatives. And then BMI less than 25. So really looking at the higher BMIs here for this, the population that I was in, and then collapsing down 1 to 2 together, 3 to 4, and then greater than 5. So after all was said and done, and I had the new categories, you can see that the trends pretty much stayed the same. Lack of consistent trend across my data. This 12 stayed significant. Before it was 12 to 13, if you'd recall. 12 stayed significant. And then the nulliferous down here stayed significant, but for the rest of my data, I did not find, and I did not find any significant findings. So at the end of the day, what does this tell us? This tells us that these are not the risk factors. The risk factors that are identified for mainstream population are not the risk factors in our population in Turtle Mountain. So there are different factors that are driving the breast cancer in this population, and research needs to be conducted in order to determine what those factors are. I was able to, and I reviewed this already, just talking about my data and what I've seen. As far as discussion, the Gale risk factors, these are the, age at first live birth, age at onset of menstruation, number of previous benign breast biopsies, number of first-degree relatives are not risk factors in the American Indian population in Turtle Mountain. Additional breast cancer risk factors that could be considered that may be driving the breast cancer risk and that should be looked at are parity, age at menopause, oral contraceptive use, hormone replacement therapy, alcohol use, body size, obesity, smoking, diabetes, and breastfeeding. The things that can affect what we're seeing is the type of study and the analysis conducted. Some studies stratify the data by menopausal status. My sample wasn't big enough to do that, so maybe what we're seeing would change if it was stratified by menopausal status, and there was a bigger population, so maybe looking at risk factors at the geographic level, at more like across the Northern Plains to include a bigger population of American Indian women, including more risk factors. These are risk factors specific to postmenopausal women that have been identified as risk factors in other populations: having a twin birth, increased birth weight, childhood obesity, adult height, obesity, young age at menarche, age at first live birth greater than 30, nulliparity, and age at menopause, and hormone therapy. The nature of breast cancer itself can affect what we're seeing. The risk factors identified, the magnitude. Tribes are not homogeneous. They differ in their culture, environment, healthcare, and behavioral health, so that needs to be considered as well. In summary, data-driven breast cancer risk estimates will help us to predict breast cancer risk. This will help us to decide which factors are important, which will help us to design interventions and raise awareness of the risk factors and improve the overall health of the population that we are, population of interest. As far as future directions goes, potential next steps would be to conduct a population-based study. This type of study has not been conducted for breast cancer in the American Indian population, and it would make sense to do this type of study. However, they can be very expensive. They are very expensive. Include other geographical regions and explore additional risk factors. Miigwech, thank you.